talk about some of the key program considerations. What are we kind of looking for here? What are the goals? The setting, who's eligible? And then we'll get into some of the basics about what our area does as far as rates, billing, what happens if the member may need an extended stay, and what's expected at discharge. Next slide. Here's how we're defining it. This is almost straight out of the statute. It is also covered in the National Standards for Recuperative Care. And it's a model of care to prevent hospitalizations and provide medical care and support services for members who are experiencing homelessness or are unhoused. This can be people that are too frail to recover from a physical illness while living in a shelter or out on the streets. So consider the person that has a home would go home in this case, but since they're living on the streets or in a shelter, they may be too sick to recover after they meet this type of criteria. We're considering that this type of person would not meet another higher level of care. So they'll be coming out of the hospital, would normally go home, and can't really, we're concerned about readmission. Maybe they've got a wound that's need to be cleaned and dressed every day. Maybe they're a new diabetic. And we're gonna stop a second. There's a few people that still aren't hearing. The suggestion is that you go out and come back in again, and you may be able to hear. Most people are hearing on our end from what we know.
Yeah, sorry, I'm going to interrupt Lori. So I am checking Lori's audio and it's working on our side. So you have those who are online that can't hear, you have to check your audio on your side. So when you log in, if you cannot hear, you have to log back out and then log back in and select that you want to use computer audio. If you are using your phone or your tablet, and that's one of the reasons why we suggest to use computer, because if you're using those, it might not work and you won't be able to hear. So I am also putting in the chat what should be done for the audio. Thanks.
Thanks, Lee. Okay, next slide. I think Lee's typing what needs to be done. Thanks. Based on a lot of the communications we've been getting, I did put together just thinking about some of these key program considerations. When you're talking about servicing in a recuperative care setting, these are the things that are kind of key to the program. An admission to recuperative care is basically going to be driven by a physical medical issue that the patient/member needs once they're discharged from the hospital, or that the provider has seen them in the clinic and thinks that they would do better, may not need a hospitalization if somebody can take care of them. If you're the facility and you're considering how are you going to get these services, you'll be able to offer or contract all services as on the provider assurance statement. So I did get a couple questions early on. Can we have a narrower focus? And the answer is no. We can't focus on, for example, mental health. We need to be able to offer the full plethora of services. The other thing for people that are new to this, be familiar on how licensure is structured. For example, a nurse just can't be hired to work on their own. Nurses work under the directions of advanced practice providers. Most of the time, you would want to be partnering with a service that already has all this credentialing in place. The other thing is each provider that you're working with doesn't have all the competencies they may need to care for the patient. So you have to understand how would you assess competence if you were going to hire the clinical folks versus going out to partner with the service. Next slide. The other key thing here is this program is designed so that members get consecutive daily services. If there are no services from a healthcare provider for that day during the member's stay, the room and board is not paid for that day. So that's a key thing to remember. Remember that in your facilities, within the setting, the statute and the manual tells us that there must be staff available within the setting to provide a wellness check as needed. Minimum of every 24 hours. We're assuming that most facilities would have somebody there that could check more often, but at a minimum, every 24 hours. They may only need to go to the member's room or check face-to-face, check the member once a day for a wellness check. This is over and above the daily services that a provider is offering the member. Next slide. The other thing to consider is any clinical program in most settings has some type of standards set. There are community standards for certain things and there's national standards. This program, Standards for National Respite, has a national institute. National Institute for Medical Respite Care is at nimrc.org. You should be familiar with these standards. And once you become familiar with those, see the information in our manual and look at the national standards, you'll see that a lot of that, and our statute, a lot of that aligns. Next slide. So what are the goals of this program? What are we trying to do for our members? We're trying to reduce readmissions so they don't have to go back into the hospital. We're trying to decrease emergency room visits. Any of you that are involved in emergency care these days knows that it can be a long wait time in an emergency room to be seen. And this also, there'll be a physical reason for the patient, a physical issue for the patient to come to recuperative care. This also gives the other ancillary services that are listed on the provider assurance statement. This also gives those people a chance to coordinate with the member and possibly even get them placement after they're done in recuperative care. And people are asking about the slide deck. Lee, are we doing anything with the slides after? Are we going to make those available?
I'm referring them to our provider manual, where all the policy billing is located there.
Great. That is true. Most of the information is provided there. We can put can we put the link for the national standards? Can you get that off the slide in the end and we will put that there.
Okay.
Thanks. Okay, next slide. So per statute, this is what we're saying as far as settings. Recuperative care may be provided in any setting, including but not limited to homeless shelters, congregate care settings, single room occupancy, and supportive housing. That's what we're looking at. Next slide. Setting requirements, if you've seen, a hotel could count depending upon the setup. Yep. Somebody just asked if the hotel count. We have a lot of people, as you can see. I don't know if you can see the attendance today is over 500 people. So one of our thoughts is we'll take the questions and we'll put out an FAQ after the meeting if we can't get to everything. So be patient with us and we'll try and get everything answered that we can. Here are the setting requirements for the facility. These are the basic requirements to provide recuperative care. 3 meals a day. I know a lot of people that had questions on what does that 3 meals look like. I think we're going to have to determine what the patient needs, what's the plan of care for the patient or the member, I should say. By that time, they're not really a patient, to determine what's needed for the 3 meals a day. Environmental services, just like any other facility, the place has to be cleaned, bathrooms clean, kitchen clean, all the basics. Access to a telephone, secure place to store belongings, and staff available within the setting. And then being able to check on the patient every 24 hours. At least. We're hoping more. Next slide. Eligibility. Who's an eligible member to receive the service? Statute says to not be a child, so obviously someone with regular medical assistance, 21 and over, and for Minnesota Care, it's 19 and over. They have to be experiencing homelessness. I know that someone brought up early on when we were talking that includes people that might be couch hopping between friends, family that really don't have a home to recuperate in. Somebody that needs short-term medical care, a period of no more than 60 days is in the manual, but we also have a mechanism to extend that if we need to. We'll talk about that in a little bit. Somebody that needs assistance with things like wound care, medication management, ADLs. We don't anticipate that most members would be there for 60 days, possibly 5 days. Maybe they're a great example is a new diabetic who is just learning to give themselves insulin. Might need some help with medications for a week, 2 weeks. Maybe somebody's in a cast and can't get around like they normally can with all their belongings that they're trudging with them every day, and they need some help with their ADLs. However, one thing that we've stressed in these programs is each program needs to know their limitations. We wouldn't expect someone to be in this program that needs total help sitting up, getting up, walking. Normally, they would qualify for a higher level of care. And we know that in the homeless population, there's certainly going to be some behavioral health need. Make sure to assess that those needs are not greater than what can be managed at the facility within the setting. And once again, that also kind of comes back to competence of the providers that you're working with. What is their competency? What is their specialty? What are they used to working with? What do they have experience with? Next slide. Now we get into more of the nitty-gritty as far as claims, payments, rates. There'll be 2 claims. One is a facility claim. On that claim will be room and board will be paid from. Room and board currently is around, if I recall hearing, around $34. It's the same across the board for anybody in medical assistance getting room and board rate. The next claim will be, what else do we have here? Sorry, what else do I need to say on facility here? Another key thing, the facility claim will not be paid unless we see a provider services claim for the same date. We're working out in our system how that's going to go. Another key thing to tell you today is based on a large amount of legislation this year with a lot of changes within our system, there are systems delayed for claims submission. But you'll see a provider news come out this next week that lets you know that. We're looking at least 3 months out. So that's a very key item for everybody to know today. Claims will not be able to be submitted for at least the next few months until all the systems work gets done so we can, and programs so we can reimburse you. And then the other key there, I'll reiterate that the facility rate is only paid when we see the provider claim come in the door. If you're working with a MA patient that has a different insurance, the insurer will pay the provider claim. MA will always pay the room and board rate. So you'll be sending the room and board claim or the facility claim into us, and the provider professional claim will be going into the insurer. Next slide. As far as the recuperative care rate, we talked about the facility claim will be the room and board rate, and anything that falls under the room and board, the food, transportation to another appointment, etc., will fall under that claim. This claim is for services. There'll be a specific code to add to your professional claim that shows us that it's a recuperative care claim. And that will be that code will get you the bundled rate of $300 a day. We will also be asking that you still list the services you provide. We're going to want data just for our quality purposes to determine what exactly is being done at these facilities and what care have these patients needed, and that'll be great for our data as well. What we're expecting through the bundle payment is basic nursing services, monitoring the patient's health, pain level, wound care, medication support, patient education. Once again, we kind of get back to that diagnosis piece and what do they actually need, and a plan of care. You'll want some type of plan. Why is the patient there? What is the patient going to be getting every day for these services? Then while they're there, any chance that we have to help with legal services, communities, social services, anything, possibly placement, this would be the time to be able to do that. And then just monitoring and follow-up, just kind of like what I talked about. You'll want to plan for each of the members or patients to determine how things are going and when they can possibly be discharged. Next slide. And then this is just a little bit more about claim submission. When you're initially enrolling, I think there's going to be a lot of enrollment questions, and that is not my forte today. That is probably what we'll put an FAQ out regarding. I know a lot of people need more information on exactly how to get started. We will also be putting the phone number to provider services in the link. That will be an excellent phone number for you. Those people take your question and route it to the right person and keep track of the question to make sure it gets answered. Once again, you might have to be a little patient, but that's how the process works, and that's the best way to do this, so you don't get tied up in somebody's email and you never hear back, etc. So these are the claim formats. You'll need to learn about the 837P, that's a professional claim. The code that's going to go, there are certain CPT codes and certain HCPCS codes that can go on the claim, so obviously you'll need somebody to code. The diagnosis code on the claim that will either both of these claims that will identify recuperative care is T2033, and I believe that's in the manual, but that's a key piece of information to know. On the facility claim, you'll need condition code 7017 that also describes to us that it's recuperative care. And risk services, I think I said this earlier, but facilities that are rendering services will need to submit two separate claims, the professional services claim and the facility claim. And then to reiterate this, billing will also look at the MCO coverage and will carve out the facility claim to be paid by MA, so that claim always comes into us. Next slide. Now we get to extended stay. What happens if you have a member or patient that needs to stay for longer than 60 days? A great example probably is the wound care patient who they might be diabetic, they might have a wound that's really needs help, and maybe you're sending them out to doctor's appointments, but they still come back with new orders telling you that they still need to stay, they still need that wound to look a little bit better. So within the manual, you'll see there is a recuperative care extended stay request form. The form needs to be filled out with any pertinent medical information so that our third-party reviewer, KeyPro, and on the form that you'll see their fax number to send this in. And then they'll approve, and then you will proceed in getting payment again for your claims. You'll have to have a prior auth number in the system after 60 days to continue to get paid for recuperative care services. Some other key things to know: 60 days is not an annual time frame for recuperative care. If you have a member that was in for one thing and all of a sudden is in the hospital again for something else, comes out 2 weeks later and needs to come to you, day one starts over. So it's not an annual 60 days, but there will have to be records or proof that it's a new issue, new admission, new things going on. And then, as I said, prior auth will need to be in the system if they are there past 60 days for you to continue getting paid. Next slide. So in the manual, it also talks about when can you discharge the patient from your services. Well, the good thing is we didn't discharge them from the hospital right out to the streets or wherever kind of they wanted to be. We actually had housing for them, which is obviously one of the main goals of this program. But before they leave, there's still a responsibility to ensure that there has been an improvement, or that something didn't happen while they were at your place that they need extra care. Maybe you're sending them back to the ER. Maybe you're sending them back to the clinic. The provider needs to see them again, and maybe he's going to readmit them to the hospital. Maybe something happens. So just a piece saying, has this patient improved? It can be as simple as that. Enough said about that, I guess. Next slide. Okay, now we know there are plenty of these. Lee, how do we want to handle the questions today? Do we want to read some of them from the chat, or how do we want to do it?
Sorry, my mouse wasn't working. So yeah, we can read some from the chat. I did respond to some of them already. So we'll just go through as what we can go through, and then we can also do FQA sheet as well too.
Yeah.
All right, so one of the first one is there a maximum or minimum bed requirement in housing in a house setting?
I would say no. We haven't seen that anywhere. There has to be a maximum or a minimum.
Okay, and then people are asking, there were a couple questions who were asking, does a house count as a setting?
It can count. Mm-hmm. If you can provide all the services listed, it can count.
Let's see.
And I guess remember, as members of my group have talked through this program, remember we're showing you the program. We're showing you, your requirements to promote the program, but take into consideration if you're going to use a home, what does the home need? Does it have stairs? Can the members climb stairs? Do you have enough room? You have, based on what issues may be with the members. Somebody asked me last week, well, can they share bedrooms? Think through that. Is that a smart thing to do? Do you want two people with different issues in the same bedroom? So there's a lot of those basic things, I think, that you have to look through and think through in this case. Because in the end of the day, you're responsible. So, next one, Lee.
Another one is, I don't see a physician as an eligible provider. Can a physician provide the service and it be reimbursed?
Good question. The basic answer is yes. But the other answer here is, within this setting, we're looking at lower level services. That's why they're here. They're not at home. If they had a home, that's where they'd go. But they're coming to this home, this setting, to receive services that maybe some people could have done on their own. Some people could have a family member done. But we're saying, and the other thing to consider is, if they're seeing a provider, they can still go to the clinic and see the provider, and the provider can bill. So this is services that a provider is asking, probably away from where they are, to be done. This patient has terrible hypertension. They never manage it. They've got new blood pressure medication. We need a nurse to monitor their vitals every day and make sure they take their medication. So also remember, and I just talked to one of my friends over at the board to make sure I was having all this right. If you hire a nurse, the nurse only functions under a higher level provider with orders. So the orders can come from a clinic, but you're going to be best off using, unless you are a shelter that already functions with staff at the shelter who has a medical director. Providing services if you don't have that set up where you are, it's going to probably be better to partner with a home care or somebody that already has all the compliance in place, understands everyone's licensure, understands competency. As a nurse, you not only just function under your license, but you have to somehow show competency in what you're doing. So if you hire a mental health nurse and now you have orders from a provider for wound care, when's the last time the mental health nurse has done wound care? So it's all those different things that we don't necessarily offer through the DHS, here's what we're doing, but all the things that you have to think about when you're hiring people that function under a license. Next question.
So the next one is, their housing stabilization provider, can they also apply to be a recuperative care?
If they're what?
They are a housing stabilization provider. Can they also apply to be a recuperative care provider?
Let's put that on the FAQ. I think somebody had asked that already, and I remember early on we had conversations we didn't want the lines to be blurred between somebody that needs care and somebody that actually you're trying to get them to extended housing. Mm-hmm. But I'm not specifically sure on that answer. If I have anyone else listening, any of my team that can answer that, that would be great.
Yep. And also, recuperative care cannot just be an add-on to your already enrolled housing stabilization provider type. The recuperative care is a totally different service that you have to apply for, and a new provider type will be created for you. Let's see. Let's see. If the client is not provided a wellness check, that means that day we cannot bill for that room and board, right?
A wellness check is different. Yes, the room and board needs to have someone there to check on people. That's over and above the other type of services they're getting. That would be correct.
And then someone that has, would a house work, and are there any zoning requirements? And I did reply that a house will work, but right now we don't have any restrictions with zone requirements.
And see, that's over and above my knowledge. Mm-hmm. Starting a business in a home will be an area that you're going to have to research. That is, our group can't answer that.
Let's see if there's anything else.
Thanks for all the questions. Just be patient with us.
Someone asked, is it okay to start a woman's only recuperative care facility? And what I responded to was that it's up to the organization to, once they are enrolled with us, then they can decide what members they want to serve.
Yeah,
as an organization.
I think that would be fine. And in the, when you're talking about safety, that makes sense to me.
And I did get a couple questions on is it one member per room, whether if it's a facility or housing?
I don't think we would answer that black and white, but I think you'd have to really think about that as far as your business and safety. Maybe there would be a time that it would be appropriate, but probably not all the time, would be my guess.
And then another one is who does the placement or who refers the patients?
Most of the time, because this would be a new business for you, those are the things you're going to have to think about. How do you market to the hospitals, the clinics, providers that may use your services? It would normally go like this. A patient's in the hospital. There are nurse case managers and social work case managers that work in the hospital and are looking at the patient's plan of care prior to discharge to make a discharge plan. And this will be a new thing in Minnesota for a discharge planner to say, I hate to send this person back out, but this is where they live, this is where they want to live, so I'm going to send them back out with strict instructions on how to get their wound care and knowing that it might not be a great setup. Now, if they have a list of recuperative cares and something seems to match the patient, they would maybe make a call. They would make a call to you to tell you that they have a patient available and do you have a bed available.
And then another one is, what if the patient has their own cell phone? Because one of the setting needs is to have that telephone service.
I would say that doesn't matter. As a facility, it's saying that you need telephone available.
Then we already answered how many clients can you have in a room. Can multifamily property be an appropriate setting?
Yes.
Multifamily property.
I mean, a multi-unit property, sure.
When you talk about working with a medical director, do you have to hire one or work with the client's medical director?
It depends on what you're going to, if you're going to offer services, you're going to want to be working with a medical director because you have to have somebody that's, even though the cares that are being given are not extremely high level, these people are still working under their licensure, which means a lot to them. So they're going to want to know that they've got a resource.
And then another one is, can recuperative care be provided in a vacant ICS unit? And I think we're still figuring out the ICS part of that, right, Lori?
I see one come through that I'll answer right now. An RN cannot be a medical director. Nurses practice under advanced practice providers who are doctors, nurse practitioners, physician assistants, anybody that can write orders. So nurses are functioning under orders from a provider.
The other one is, can recuperative care be provided in a vacant ICS unit?
And we were saying that we're still checking on.
Yep. And then the other questions were, after 60 days expire, is there a transition plan?
Yes, that's part of discharging the patient from recuperative care. That is what whoever is providing services is determining as you go. How long should the patient be there? Do they only need a few days? Do they need a week? The orders come from the provider, from either the clinic or the hospital.
And that says, if there's a possibility of needing an eviction or termination of service without the client having a safe place to go, what's the next step?
I think the statute tried to stay as general as possible because we know the reality. The hospitals have the same reality. The hospitals need to discharge a patient they have to have a safe discharge. So the documentation would need to be there that, you are that stopgap that hasn't been there in the past, that you are the safe place. Once they have improved, then they can leave your place. It might not be huge improvement, but enough where they're functioning better than if they hadn't had a recuperative care area at all.
How do you want us to relay the homelessness in the provider documentation?
There are, whoever will be coding your claims, there are specific homelessness codes. Currently in 2024, there are 3 of those. So who's ever doing your claims can look those up in the code book, but that's how that's coded. And it probably wouldn't be the only code on the claim, because clearly this person has another issue. Diabetes might be a code on the claim. Depression might be a code on the claim, but homelessness has to be on the claim somewhere.
All right. The other one is the client need to check all these eligibility criteria or just one of these criteria would make them qualify for the service? And I did respond to that. I relayed that the member needs to meet all of the criteria that we list in our provider manual in order to be eligible for recuperative care services. If a client is not provided a wellness check but has utilized the bed, can I still bill for room and board, or is a wellness check mandatory regardless of them sleeping or not?
You cannot bill for room and board unless the client has been checked on once in 24 hours.
What documentation is required for members to prove their eligibility? How does DHS verify the eligibility of members for the recuperative care program? So as providers, if you are enrolled with Minnesota Healthcare Programs, you should have a Minutes account once you are approved and enrolled with us. And the Minutes account is where you can check for the members' eligibility to see if they are on a eligible medical assistance program. And so if they're on medical assistance or Minnesota Care, when you look at eligibility, and if they're 21 and older for MA and 19 and older for Minnesota Care, then those are the eligibilities that you will see in Minutes. So that's how you would check. Again, people are asking, they have to meet all their eligibility requirements. Yes, all of them. It cannot just be just one. Does a nurse need to be supervised by a practitioner or a physician?
Yes, I mean, unless you have another way to determine the competence of a nurse, yes. They at least have to be practicing under orders from their provider from the clinic or the hospital at the very least. Most nurses are not going to want to take a position where they don't have a medical director up above them.
And someone says, can the service be provided in a setting that already have other enrollment types such as CLS, CRS? So the person that is asking, can you clarify to us what CLS and CRS is? And then someone asks, is the room rate daily is $34? So yes, it was $34 for the room and board. In order to submit an application, will I need a facility site, or can I apply and get a facility setting at this later at the same time? So when you're applying, you will attest to saying that you have that setting. You will attest to basically saying that you have that facility, that 24-hour ready for that member to come in and stay. And then another one is, can recuperative care services be provided in licensed assisted living facility? And Lori,
No, they're already living somewhere then.
Okay.
They already have somewhere. I I would think any other licensed place, you would have an issue with your license, your licensure. If you're in assisted living, I will be surprised if they would approve recuperative care beds in your assisted living.
Okay. If clients needs help with activity days, ADLS, and you don't require 24-hour, how does that work?
We do require 20.
Yeah.
If you don't require 24-hour what?
ADLS, is that?
Activities of daily living. Yeah.
Mm-hmm. Yeah.
And if we don't require what?
So if a client needs help with ADLS and you don't require staff 24-hour, how does that work?
Oh, that's why there's staff available as needed in the facility.
Is there a limit to how many units that can be in a room, or if there's a minimum? Lori already responded to that. She said, no, there's no minimum or maximum. Can we use assisted living along with recuperative care services? And Lori responded to that they're already living at the assisted living, so you would not be able to use the recuperative care services.
And if they weren't, and you were thinking about opening up beds, as I said, I can't imagine regulations would allow that in the same setting.
Have the MCO set up a process for provider enrollment yet?
Good question. I think a lot of them have it in the works since it was just a new program January 1. So keep an eye for any information from the MCOs that you're thinking about. Normally, if we're setting up a new program, they're probably going to be a little bit behind where we are. So the fact that we've got some delays, they certainly won't come up before we do.
Let's see, they're talking about, can you hire a nurse? Do you need advanced nurse practitioner or practice?
No, you don't need an APN. In fact, as we were talking about earlier, an APN can still see the same patient in their clinic, but they may be the ones writing orders for whoever is carrying out the service, whoever is at the facility.
Will enrollment need to be specific for each location? Will you have to enroll with MCOs for every location? So for the MCOs, they would have their own rules regarding enrollment. So you'll have to contact the managed care organizations. And then for enrollment with us, if you have more than one location, that means that you will still be set up as a recuperative care location, but you will be consolidated, and those different locations that you provide recuperative care, they will be consolidated under that one recuperative care file. Are we expected to utilize EHR to document these services?
No, that will certainly be an interesting focus for everybody starting up a new service. What does your documentation look like? What does each licensure require? At the very least, you would have the orders from the hospital or the clinic that you're working under. You'd have some type of plan of care and some type of note. Just if the nurse is functioning, she's going to want to chart her. If she's doing vitals daily, she's going to want to chart the vitals. She's going to want to maybe chart an assessment. If she's doing wound care, she's going to want a chart that she's done the wound care and what exactly specifically she's done, etc.
Okay. I see someone asked about billing. So billing, we do have information out there for billing, but I would ask for providers to hold off on any billing questions until you are actually enrolled as a recruitment care providers, and you start providing the service, and then when you start submitting the claims, you can call into our call center regarding how to bill for the recruitment care services. But yes, right now we do have billing information. In a bit, I will also show where that information is located. So we'll just go through some more questions, and then I'll just go to our provider manual and show you guys that. Will we be able to enroll without having the nurse and staff and then hire after we are approved?
Part of the assurance statement is stating that you have the available staff to care for the member. So I would say you'd have to get everybody coordinated and then be able to attest that you have what's needed.
Yep. Another one is this available for new enrollment providers, or is it only for existing providers? It is for anybody who is interested in enrolling for the recruitment care program. And then they will go through enrollment and attest that they meet the criteria for enrollment. So it's not only for existing providers.
That also brings up something else that I've been asked a few times. And we're not specifically sure how it's working yet, but remember that anytime you're enrolling as a facility with MHCP, there may always be a potential for some type of audit or site visit. I just wanted to put that out there.
It says, can you clarify what is meant by experiencing homelessness or are unhoused in terms of eligibility?
I think a good resource might be if you take a look at, I've forgotten what it's called already, the recuperative care standards, and that website goes through all of that, talking about how to define it and kind of giving you an idea of who they're talking about, who they want to care for. But it's basically anyone out on the streets that does not have a home. It can be, the one example I used earlier that I hadn't thought of in the past was somebody that doesn't have a home but might be, couch hopping, but really doesn't have a stable place. That person would be considered unhoused, homeless.
All right, so we only have 5 minutes left. I know we still have a lot of questions. So the remaining questions, we will track those questions, and we will do a FAQ. And then right now on the screen, you should see the manual page. And the manual page gives information regarding billing and also the policy that Lori just went over. And I'm just going to post it again into that chat. But before we do go over that, I'm going to show you guys the page for how to enroll. So how to enroll is also in our provider manual page. And on the left-hand side, there's a section that says Provider Basics. And then in the middle for provider questions, it says Enroll with MHCP. And then when you click on Enroll with MHCP, at the last link, it says Eligible Providers. And then there's a table for organization providers. And when you scroll down, you will see a link for recuperative care. Once you click that link, it will let you know how you can enroll for recuperative care. So there's two ways of enrolling. One is you can enroll through our online enrollment MPSC portal. And there is directions on that. Or if you choose to submit your enrollment forms to fax, you would complete these 4 forms, which is the organization, the disclosure of ownership, and the disclosure of ownership would relay who owns and has a control interest. Then you would complete the fee for service or the fee for service in managed care organization, and then you would also complete the recuperative care assurance statement. And again, that assurance statement, if we open that assurance statement up, I'm going to open a new tab. So basically, this is one of the last forms that you would complete. So you are ensuring as a provider or organization, as an organization, you would have 24 access to a bathroom or shower, sink and toilet. You have 24 access to a bed, access to 3 meals a day, availability to environmental services. As Lori mentioned, cleaning service, cleaning, the location, the kitchens, the bathrooms, and the rooms. Access to that member has access to telephone, a secure place to store their belongings, staff available. And lastly, this is one of the important things, is that you as an organization, you are testing that these following providers, you are testing to the program that you have the appropriate providers to be able to provide the cover services. And then when we go back to the enrollment page, then you'll also have to send in proof that you paid a fee for trying to enroll as a recuperative care provider. And then I'm going to go back to the manual page. So here's the manual page. We are looking to update this manual page a little bit and clarify the eligible providers. So look out in the future. We'll send out a provider news that we did update this section. So we are working on that. But we have a section of who can be eligible providers, and then eligible members, as Lori already mentioned, and we did get a couple of questions. You have to meet all of the criterias. You cannot just only meet, the member cannot just only meet one of the criteria to be able to get recuperative care services. And then we have a list of what services can be covered for recuperative care. And then we have information about the settings. So as an organization, again, your setting needs to be able to have these minimum. And then what are non-covered services, and information about authorization and billing. And someone did ask about how do they bill. So there's two types of billing. One is for the recuperative care services, and the facility is for the room and board. And someone did ask, so you will bill the T2033, and then on the same exact claim, you will bill the services that was provided that day with a zero charge. And again, as I relayed, that once you are actually enrolled as a recuperative care providers, if you start providing services, and once you want to submit your claim, you can call into a call center, and I can assist you with billing. All right, so it's 2:31, and Lori and we will look at your remaining questions and create a FAQ. And once we're done looking at the questions, and completing the FAQ, we will post that into our provider news and send it out.
Thanks for your interest in offering care to homeless members. We appreciate it.
All right. Thanks, everyone. Have a good day.